Well, we have some students that were late coming in for the quiz, but I am not going to stop class because they were late. One thing about being a nurse is being on time and getting your whatever treatments done in a timely fashion. So just remember that being late is not acceptable, and I did give you an opportunity to make up that quiz. Okay, so today it's week 8. Next week, as I said, is your exam. We still have another review tomorrow at 11 a.m. with Professor Brunel. I just posted to my students the uh, Dr. Yamraj review. I had just gotten it. I did check the other classes. My review and the Cahoots are already posted in the announcements. So you already have that information. So I checked it on you while I had a moment with you taking the quizzes. This week, oh, and I checked on that case study, Latrice, and you have a grade. Latrice, Angelique, Tamu, and Kenya, you must be on camera. So if you could come on right now, or I have to eject you from the class. And I don't want to do that. Tamu, Latrice. There's Tamu coming. Latrice, are you there with me? Is anybody a friend of Latrice? Tell her to come on the camera, please. She cannot lose any more time, so please get her on. I don't want to have to eject her and she won't get the attendance credit. I don't want to do that to anybody. Thank you, Candy. Okay, so what is due this week? Urinary tract infection and burns and collect studies and a discussion question. So there's a lot of things due and you're studying for an exam. I do know next Thursday again at 2 o'clock, I'm meeting up with a small group to study again as a review. I'm not posting it as a big announcement, but anyone who is right there wants some help, we're going to be going over those concepts again, not necessarily in the form of the PowerPoint, because you can study that again, but maybe talking about those different systems of the body, what terminology you need to know, okay? So I will be doing that again on my Zoom, 2 o'clock next Thursday, if you want to join me. I had a student from another class who's requested it. So I'm always open for anybody who needs help. So let's go ahead and let's start with our first PowerPoint. Latrice, where are you, my dear? I'll come back in 5 minutes to look for you. There she is. Thank you, Latrice. I didn't want to have to eject you. That's not my goal in life. Thank you. I'm sure you're doing something with your baby boy. All right, let's go into some metabolic conditions. Metabolic, you think of that, and what do you think of? Well, let's talk about the endocrine system. Well, the endocrine system is all about hormones, whether in the pituitary gland, thyroids, parathyroids, adrenal glands, your ovaries, your sexual hormones too, okay? So it put it right into the blood and it does something. All one of these do something, and we want just the right amount secreted. Too much or too little can cause problems too. So sometimes if we don't have the proper metabolism, we're going to be seeing signs and symptoms. For instance, if you have a child who is not gaining weight or not stooling at birth, some things are telling you something's not right, and they're going to start looking. And one of the places that we look at is the endocrine system. So lethargy, poor feeding, failure to thrive, that means not gaining weight, vomiting, enlarged liver could be a problem of something going on with metabolism of the newborn. And we know the endocrine system, whether it's the pituitary, thyroid, or adrenal glands, all play a part in that. So sometimes you do not see these symptoms in a young baby. Sometimes they have to get a little bit older. And sometimes it's the stress of getting older. And, even little 2-year-olds are little worriers and they do stress about certain things. And then you're going to start seeing it. Sometimes when you have a child, as I said, cognitively, they're not where they should be. They're not doing that fine motor, pincing and walking and rolling and lifting their head up, even as a younger infant, They're all telling you something's wrong. And usually that mental is all about thyroid, believe it or not. Thyroid hormone is that important. It has to do with mental, cognition, and developmental, doing all those developmental milestones that we look for. Sometimes we'll have a child who has seizures that's telling you something's going on. Sometimes you can smell it. Just think about diabetes. Can't you smell that sugar, that acetone breath? So there's some things are telling you something's going on. So what do we do? How do we study this? Well, we can have our ideas and we could think, well, it could be this, but we have to have facts. So x-rays sometimes or ultrasounds can help. That little PKU, those little circles on that little piece of paper they do at birth can tell you phenylketonuria. So it's something that will be looked for. If we see abnormalities in even the features of the child, chromosomal studies can tell. I mean, you think chromosome, you think Down syndrome, right? Well, there's more than just Downs that it could be. Biopsies we could take. As I said, that good old thyroid function will be always a part of it. Ultrasounds of anything can happen. And then, of course, 24-hour urine specimens. We can see if something is, wasting, that there's too much of this or that in the urine, or not enough of this or that, could tell us something's happening. Now, lysosyl beta hexaamidase is an enzyme that we need to digest our fats. So if we don't have something to digest fats, we're going to be losing all those calories, aren't we? And what will we see? We're going to see that the body's not getting that lubrication, right? In the nerve cells, which help with the transport of impulses, et cetera, et cetera. And it's going to cause physical and mental deterioration. They're not going to be able to turn over. They're not going to be able to walk, run, skip, button their shoe blouses or shirts, right? Put on their own clothes. So, and then mental deterioration, they're not going to be able to think. They're not going to be able probably to even talk. We find this a lot in the Ashkenazi Jewish population, and it is passed on. It's an autosomal recessive trait, so it's passed on in the chromosomes. Now, Tay-Sachs disease, the infant looks great. And then all of a sudden, about 5 to 6 months, now normal development, that infant should be turning front to back, back to front, right? Well, at 5 to 6 months, they are not even turning over and they can't even lift their head up. Head lag is when you take them by their hands and their head falls back. Now, newborns, they don't have head control. Their head will fall back. That's why your hand is always under the head. Now, at 6 months old, their head comes up with the hands. If it's not, something's going on. Now, if we are not figuring out, doing all these testings, what's going to happen? Well, they're going to end up blind, mental retardation, and it's going to be irreversible. So most of Tay-Sachs disease children die before 5 years of age because of infection, they're immunosuppressed, or malnutrition because they're not getting the fat that they need in their body. There's no treatment though. So the thing is, we need to determine what's going on. So if anything, let's just prepare those parents what's going to go on, right? Because Tay-Sachs disease doesn't mean that there's going to be your child growing up for a lifetime, okay? So, and we need to let the parents know they're carrying this disease. Now, hypothyroidism, your thyroid's in your neck and it secretes hormones, thyroid hormones, right? Sometimes infants are born congenitally and they don't have enough thyroid hormone. We would actually see at birth a child who's constipated, which means no stool in the first 2 days. That's one of the big signs, believe it or not, that alerts the medical community, let's test those thyroid hormones. Or even cystic fibrosis does the same thing, but we'll be testing for it. And if we do not give those hormones back to the child, the levothyroxine or the synthroid, they're cognitively are going to be delayed. So we need to make sure that we replace those hormones. Now, sometimes all of the symptoms aren't there. And the only way we're going to figure it out is if we're looking at that child and evaluating their developmental status. And if they're not where they should be, again, we got to go back to doing that testing, find out why, because it could be many things, as you can see. It's a cute little baby, huh? You know what that is? An umbilical hernia, isn't it? That's reducible. You can put your finger in it. It's going to be okay. Thing. Hypothyroidism, what do you see? Well, what do you see in adults? You're tired, you're constipated, cold intolerance, dry skin, sparse hair. Same thing with children. But these children also need it for cognition. So they'll be delayed. So the infant sleeps a lot, tired, the tongue becomes big, and you're going to hear as they breathe, almost like a Down's child, right? A big tongue. The skin is dry, they're in a perspiration, hands and feet are cold, they're floppy. Remember, cognition, their development's going to be delayed. What did I say about constipation in the child with hypothyroidism? Chronic, but adults with thyroid hypothyroidism, same thing. Hair is dry, it's brittle, and it's almost sparse on the head. And again, if we do not treat this, this child is going to be delayed. It's going to be irreversible mental retardation. And because they're developmentally can't think, can't do, they're going to be physically disabled too. They may not be able to walk. So juvenile hypothyroidism sometimes is acquired later on in life. One of the big things we see is this lymphocytic thyroiditis. And another thing we could call that is Hashimoto disease. And it's an immune thing that happens when they're in that pre-adolescent growth spurt. Remember, they grow really a lot right as they enter their adolescence, that 25% of their height and weight in those 2 to 3 years. And that's when we will see it. And what are we going to see? Well, same symptoms as we would see in that younger child or an adult. You know, they'll start with constipation and dry skin and being tired and not growing, all of those things. And even cognitively, you know, maybe they're not thinking correctly when they used to be. Now, because brain growth is nearly complete by 2 or 3 years old, sometimes mental retardation and neurological complications are not seen. So sometimes they get to a certain level and they seem okay, but it's harder to tell. So the younger we catch these children, actually it is actually the better. Today, we are doing screening tests for hypothyroidism because we know how important the thyroid hormone is to good growth of children. As I said, we're going to be given oral medications. Now, what adults take, children take, but they do it in mics per kilo, milligrams per kilo. It's not just one pill fits all in the adult world. It will be appropriate dose for them. And they do have it in a liquid. So it's a synthetic thyroid hormone, levothyroxine Synthroid, right? They will need to be tested regularly, making sure their levels are okay. Remember, kids are growing. They are going to constantly needing increases of doses, aren't they? And we also, if we didn't catch it till later on in the infant life, we're going to have to start therapy. Remember, I've always said early intervention, these children can catch up very quickly. Just because a kid at 1 year maybe can't roll over yet, does not mean we can't catch them up with speech and physical and occupational therapy. I've seen incredible things happen where children get the hormone, they've got what they need, their cognition gets better, and they catch up with the other children. So it's pretty neat to watch that. Now, sometimes in the first months of therapy, you know, they get this, well, when you don't have that hormone, you feel down, you're sluggish, right? Now you start taking the hormone, it's almost like speed. It speeds you up, okay? So sometimes you can't sleep, you get aggressive, you're jittery, you can't concentrate, you're like, because the thyroid hormone, but it settles in, and then the thyroid hormone, we should give it in the morning. Can you tell why? Because it sort of picks you up. So definitely we give it in the morning, and it will be lifelong and lifelong monitoring. Now, what happens if all of a sudden, let's say they forgot they took it and take it again, right? And sometimes you get too much. It can happen. It's an honest mistake, but it could be serious. So if we give too much, remember, it sort of speeds you up, right? Rapid heart rate. Then you have rapid heart rate, you get this like difficulty breathing, you're getting irritability, you're speeding up, so your weight loss and you're sweating. Makes sense, doesn't it? Now, you don't have hormone. It's like, oh, I'm sleepy, I'm tired, I'm fatigued, and constipated, right? It's always part of thyroidism. So make sure if you have a child who has this, even your adults, people, this is what you're going to see. Make sure that they're aware. Part of your teaching should include that. Now, diabetes insipidus is the pituitary gland, and it controls urine output. Now, let me say this twice. Diabetes insipidus has nothing to do with blood sugar. Has nothing to do with blood sugar. It's all about urine output, okay? This is a hereditary disease. It's something that it's not a cure you're going to have. And what happens is the posterior pituitary gland decreases the amount of hormone it has that stops the body from urinating. So it urinates normally. You can have too much, you can have too little, right? Diabetes insipidus, you don't have enough hormone going out. So what happens? Drink, 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 and urinate, 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 and nothing satisfies it. So it can cause really bad dehydration. So pituitary, the anterior pituitary gland is all about growth. This is your dwarfism, or this is your gigantism. So it's either too tall, too short. It's all about the growth hormone, okay? We can, for those that don't get enough growth hormone in the anterior lobe of that posterior, the pituitary gland, we can give hormones, but they're injections. And they're probably going to be given daily, and they'll give that growth hormone up to puberty or up till when they stop growing less than 1 inch a year. It's usually about that pre-adolescent stage. Now, the posterior gland, so there's two lobes, as you can see the pituitary gland. The posterior is about having too much hormone or too little. Well, I've just mentioned about the too little amount of hormones secreted. And what happens is you urinate. There's nothing to stop it. There's no hormone that says, hey, kidney, slow down. Whoa, don't do that. So what do? There's a nasal spray or an injection. Vasopressin is the name that we give. And we know that's working when the urinary output stops urinating that much. So it decreases, it goes back to normal things. Well, opposite of that, too much anti-diuretic hormones going out, anti-diuretic against urinating. You hold all the water. You're completely filling up with water. It could be your tongue, your gums, your face, your hands. You just swell up, and you'll see that with increasing weight, and you also see it if you're doing eyes and O's in a hospital. Your intake is going to be okay, but your output is going to be nothing. How do we treat anything with fluid balance? Make sure that we restrict the fluids, and we're going to be given some sort of an antagonist to stop that from happening so that urinate just enough. Now, the parathyroid gland has nothing to do with the thyroid. You know, this diabetes insipidus, mellitus, you know, this parathyroid, thyroid, they're different. So don't ever connect them. The parathyroid's all about calcium. So if you have hypoparathyroidism, you don't have enough calcium. And what does calcium do? Makes your bones grow, right? So you might be short, or you might have this osteodystrophy, it's called, or bones are irregularly shaped because you need calcium for that. So If you don't have enough, we give some. And if we have too much and a hyperparathyroidism, we put these children on something where we monitor their calcium. We're going to give some vitamin D and low phosphorus. And that is the cure for either too much or too little. Now, adrenal glands, those are by the kidneys, right? So we have, again, too much or too little. Well, the thing when we have too little adrenal hormones, which is cortisol, sex hormones, steroids is another name, is called Addison's disease. These children are born and they don't know if they're a boy or a girl because they're going to have boy and girl type of genitalia. You could have a vagina with testicles. You could have a penis with a vagina. You can see all different things with it. I've only seen one in my career. And what they have to do is check the child out with hormones, etc., and assign a sex to that child, okay? And we're going to have to, because it's low, we're going to have to give that cortisol and aldosterone, which is what the adrenal glands secrete. Now, what happens if there's too much? Well, usually too much is one of two things. It could be, it's also called Cushing syndrome, too much. Just think of the big Pillsbury Doughboy, cushy, right? That is too much because you blow up, your cheeks get big, red, and ruddy. You get big abdomen, skinny arms, skinny legs. And these things are because of too much cortisol and aldosterone. So many times it's due to oral steroids that you've taken, like Decadron or Solumedrol, been on too long, and the body reacts over cortisol. So what do? We slowly decrease, we taper off those hormones, and usually the body will go back to where it was. Excuse me. The other thing that can happen is this little tumor called a pheochromocytoma, and it spews out things that make the body's heart rate go up and the blood pressure go up and give headaches, and sort of hard to find, but it is a tumor. And what they do is they replace it. They take it out, they go to surgery. And then if you need those hormones, depending on the tumor site, etc., you might be on some hormone replacement. Okay, diabetes. Diabetes mellitus. Remember, insipidus has nothing to do with mellitus. Diabetes mellitus is all about sugar. And what's the problem with this? The body cannot digest sugar, so it sits there. So you keep eating sugar, the blood sugar goes up, 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 up. But what does the body say? Say, I'm hungry. You're not feeding me. So what they do is they go to proteins and they go to fats and they start eating them, right? Body says, all right, I'm going to go do another food source. And what happens is you'll see ketones in the urine. And as you get diabetes, and one of the first things that we see is all of a sudden you do a urine test and you see sugar in there. Because remember, if you can't digest it, you got to get rid of it. So it does come out in the urine. So you will see that. And sometimes you're going to see them urinating. So it's polydipsia, polyuria, polyphagia. I eat a lot, drink a lot, pee a lot. This is part of diabetes mellitus. So when we eat the other body parts, it's the ketonuria. So diabetic ketone acidosis is when the sugar's up and there's a lot of ketones going because we're not having enough insulin. So what do? Well, we know that you need nutrients, right? Nutrition, nutrition, nutrition in order to live. And we need that sugar to have that body build and to grow and to be cognitively aware. So the treatment of diabetes is to give that insulin. And once they are diabetes, they're type 1. They're type 1 for life when they're small children. They will never be a type 2 because the pancreas isn't going to start making insulin. It just doesn't happen. And the thing is, we want these children to be children. Now, one of the things that I tell children, especially those who keep coming in really high blood sugars and really serious time where a lot of ketones are being spilled, especially the girls. Let's say it's the third time I've seen them in 6 months in the ER. I would go up to them. What do girls like a lot? They like their eyes, don't they? Putting on makeup and eyelashes and looking pretty. Well, look what can happen for long-term consequences of not taking care of your blood sugar and not being compliant. They could become blind. And I want you to know, telling these teenagers that has reversed some of the teenagers' thoughts and has actually made them more compliant. So it is a trick I use, but it does work in taking care of those kids because I really do care as a nurse. Now, it can, of course, it has to do with, those older people, ulcers, circulation, has to do that neuropathies, you don't feel your feet, kidney disease, all of those things as they get older, all of them will come to fruition. If these children, as young children and as adolescents, don't take care of their blood sugar. So as I said, they're always type 1, right? Type 2 is you still get a little insulin going on, so you take an oral supplement, and it helps the pancreas to secrete a little bit more insulin because there's some there. And of course, it's always diet, diet, diet. Gestational diabetes is when you're pregnant and your blood sugars go up. Now, one of the things about gestational diabetes, it needs to be treated and only with insulin during pregnancy. It's not oral. It must be insulin with good blood sugars checked. Sometimes they turn into type 2 diabetes later on in life. So it needs to be watched closely. And look at the chromosomes, part of the quiz, right? That can cause diabetes, 6, 7, 12, and 20. So what's the criteria? We've got to know what diabetes means, right? Well, in adults, it's the glucose of 100, right? In children, we give them a little more. We'll say 126. And we know that sometimes there's resistance to the type 1 is when you don't have that insulin coming in. And type 2, something happened. And a lot of times type 2 happens, especially if we get to those teenagers that are a little overweight and they're not moving a lot, that can cause it. So you can see losing weight and getting more active can reverse type 2 diabetes, but never type 1. Now, diabetes, the most common metabolic disorder. But when we look at ages 5 to 7, what happens? Well, stress can do anything to your body, but it can trigger something that stops your body from producing insulin. And then the 11 to 13-year-olds, they're in puberty. They've got all of these extra hormones going on there, and that can trigger it. Now, children are very hard to manage because they want to be up, they want to be out, they want to be active, right? And they're growing. So changing of eating habits, changing of insulins, et cetera, et cetera. These children must always have water, they must keep hydrated, and they always need to have snacks. And they could be normal, but they're going to have to check blood sugars before going out and playing a game of soccer, right? Because they need to know where their blood sugars are so they don't go into hypoglycemia, okay? So their nutrition is mostly proteins at this point, and that can actually benefit them. Usually what you see, and I saw that, and I still see this little girl in my head. She was 3 years old, blonde hair, blue eyes. She had lost weight. They checked her blood sugar in the doctor's office and sent her to the ER. I checked it and it was 600. I did a urine, she was 4+ ketones. She was a brand new diabetic and she had lost 10 pounds and she was skinny to boot. So this is what you see, typical sign that you'll see in those children. So as I said, there's those 3 things: polydipsia, polyuria, polyphagia. They're eating, but they're urinating, and they're thirsty. Again, remember, always worry about that dehydration, okay? Because they are urinating so much. Children, this quick is a very quick thing that it happens. It was in a week that this little girl, this all happened to her. But you also will see them lethargy, they're weak, they don't have energy. There's no fuel fueling their body. So they become weak and their skin gets dry. And then older girls, you're going to see a lot of yeast infections. Now, hyperglycemia, I've mentioned it a little bit, and we know its blood sugar is elevated. And if there's no insulin, the body says, I'm hungry, right? And they eat the protein and the fat in the body. It's just another food source, so they do eat it. So even if they eat more sugar, what's going to happen? It's going to feed the body? No, the blood sugar levels keep going up, 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 up. So what do we do for these children? Well, we're going to have to stabilize them. We're going to have to get them on some insulin, and we're going to have to monitor those blood sugars really, really closely. And a lot of teaching is by nurses. It's not the doctors. It's not handouts. It's us sitting with them, letting them know that they're going to have to be able to monitor and to have snacks. And it's going to change the lifestyle of the whole family. And that's the honeymoon. It's the beginning of it. We're going to be doing those blood sugars, monitoring them all the time. Should be before every meal and bedtime. And then fasting in the morning, and we're going to be looking at it. If we are seeing blood sugars that are consistently up, this says 2 times. Sometimes parents like to do a few more, but just to make sure. But they say, yeah, that's when we look at diabetes. So how else can we do and look for diabetes? Well, you got that glucose tolerance test, the one that every pregnant lady takes, right? That sweet stuff that it used to taste horrible. At least it tastes better today. But if we see them up to 200, we know we're in trouble. But that hemoglobin A1C, if we see it above 6, we know that something's going on. In adults at 6, you're pre-diabetic. 6.5, you're diabetic. In children, it's 7 and 7.5. Literally having a hemoglobin A1C between 6 and 9, which is high for adults, is good for a child because a child needs more sugar, right? That makes sense. They're smaller, they're growing, okay? Above 12, that means you're going to see all of those side effects that occur. Now, if we don't treat this blood sugar and it's up over 1,000, it could go into a diabetic coma. Sometimes diabetes is caused from an infection, being sick, and these parents need to know that also. And we know ketoacidosis is the byproduct of eating protein and fat because there's no insulin. So that's what ketoacidosis is from. You're going to see it in the urine. You're going to see an ABG, or a CO2 in an electrolyte panel is going to be decreased. Your pHs are going to be usually should be 7.35, 7.45. Great numbers. Probably 7. I've seen 6.8 before. Very ill children. They are in a hypertonic dehydration. You can smell their breath. It's called fruity odor, acetone breath. Think about a peach. Put it in a container sealed, put it in the refrigerator, forget about it for a month. It's going to start to rot, right? Take it out, open that lid. That rotten peach smell, that sweetness is exactly what DKA smells like when the blood sugars are getting up to 500, 600, okay? So we've got to be careful when we start seeing that fruity, that nausea, that altered level of consciousness. They get really weak and they can't even hold their heads up and they're pale. What is our goal? Well, we need good nutrition to grow, right? And to develop properly. So we need to maintain those blood sugars where they should. And we need to have those children understand why they're doing it so they can cope. This is not now and gone next week. This is for life. And it's not just the child, remember, it's the family also, right? So they really need to be monitoring those glucoses. You know, sometimes We have issues with the children, finances, cultures, what they believe in. So one of the things here, pork-based insulin. You know, there was beef and there was pork at one time. And remember, some religions don't eat pork. So give them a pork insulin would be against their culture, wouldn't it? So we always have to remember culture. We always have to remember financial. Well, what if they can't buy those pens because they're expensive? Maybe they have to learn how to draw them up from a syringe. All of these things are things that we're going to have to teach those parents and consider for them because they don't understand yet, especially in the beginning. Again, growth is not steady. We're going to go get taller, get a little pudgier, taller. It's just what they do. Keeping them hydrated. They're never on a regular pattern. They don't eat normally. They tend to graze, many of these children. Rarely are children's breakfast, lunch, and dinner, nap time, bedtime, all the same. Rarely in today's society. Maybe 100 years ago, but not now anymore. School-age children may really grieve, be upset, cry over their diagnosis. So you need to give them something to look forward to, right? Sometimes they might skip insulin stuff to get attention. They will do those things. So be aware of these children and what they're going through because they can, and that could be dangerous. And adolescents, you know, they want to eat like their buddies. They don't want to be different. So it's a really difficult thing for them. So well-balanced diet, show them how to give insulin, where to give it, and for regular exercise. So what do? Teaching plan, all of the things I just taught you. The pancreas, what does it do? What does insulin do? How to monitor their glucose. Where do you stick your finger? I mean, as simple as that, right? Their diet, looking at proteins and looking at calories and trying to work it all together. And then making sure they get up and they move as in some sort of exercise and not in front of a video game or a TV all day, right? Or an iPad. Remember about peripheral neuropathies and all of that circulation, skin care, foot care. Infections can really blow those blood sugars really high. So if they have an illness, you know, it's part of it. Just to be aware of it and monitor their blood sugar more quickly. Stress, emotion always will affect anything. Checking their urine, their glucose, right? Their sugar in their urine and the proteins in there. And then as they're traveling, making sure they have the proper equipment with there to take care of themselves. They don't leave their insulin stuff at home when they travel. They must bring it with them so that they're still continuously monitored and always follow up with a physician. When they're sick or need surgery, it's something that needs to be discussed. We want them to grow good and we want them to have enough nutrition. And we know that children, different size, weights, it's going to be a different combinations of food intake. And it's something that we have to constantly reevaluate for them and let them know, you know, okay, you can have more proteins now, or you can have more of this. Fiber actually decreases blood glucose. So a child who likes bran or fiber, you know, or raw vegetables and fruit, it's actually very good for them. It does lower the serum cholesterols, and sometimes because it lowers it, it can decrease the amount of insulin requirements, right? Blood sugars aren't as high. Maybe they don't have to have a covered type of thing at that point. They don't need coverage. The blood sugar is okay. The fiber goes and it absorbs the sugar and you have a stool. Always have them look at the labels. You know, it might say dietetic or diabetic or low sugar. Be careful. You know, those labels, it may have more salt or more sugar than you expect. So make sure that they read. Again, teaching is us. It's not docs. It's not the practitioners. I mean, they're busy. I mean, we have hopefully a little bit more time. So insulin is an injection. It cannot be taken orally. The gastric juices would eat it up and it wouldn't work. So it's going to be given in the arms and the stomachs and in the thighs. And it's going to be given on that 45-degree angle. So it just goes subcutaneous, not in the muscle. Children can be taught. I've had children on insulin pumps show me how to use the pump and how to give them a bolus. They're amazing children, and they really need to be taught how to do this and take control of their bodies. Always rotate those sites. If you put the same site every day, you're going to hear crunch if you put a needle down into that area. So they need to keep moving it. This is lifelong. They need to always switch it around, okay? Never put it where a blood vessel is. It needs to go into tissue. So if you see a little blood vessel on top of the skin, not there, move it over a little bit. These are the areas that we use. And mixing insulin. Clear before cloudy, right? Have you heard of that before? Clear before cloudy your insulin. And again, today we've got a lot of those pens that we use, but there are some patients who are going to use the bottle with syringes. And it's better one injection than two. Many children are on NPH and regular insulin together. So the regular goes first and then the NPH. Clear before cloudy. Now, how long does the insulin take to work? And why do you need to know that? Well, if I was to give a coverage of an insulin to a patient, a child, and I didn't check on them and breakfast didn't come, remember, it's pretty quick, but 30 minutes, an hour, it's working. I could have a child hypoglycemic and go into hypoglycemia shock. So we need to understand when the time that it takes to work on that, okay? And then we can give regular insulin through that pump device. It's really great, as I said. Children can, ones that are alert enough, smart enough, we can teach them how to program it, troubleshoot it. So insulin shock, I just mentioned it, hypoglycemia, blood sugars are low. It's because they haven't eaten or they didn't know the insulin or gave too much insulin. All of those things can cause it. Because children are children and they're more brittle than adults with insulin and their blood sugars, they are more prone to insulin reactions. So they are getting taller, bigger, growing, active, burning more energy. What do you see with insulin reaction? It's hypoglycemia. Irritable, start acting differently, probably not like you normally know that they do, and they get pale. They're going to be hungry, weak, and they're going to sweat, jittery. They're just, they can't even hold their heads up at this point. Immediate treatment. Well, if you're out with a child with diabetes, what would you teach them? Well, orange juice is great, right? We've always heard of that. How about a glass of milk if that's all you have? Got sugar in it. Hard candy, not a big ice cream or something crazy, just enough, and then get them somewhere so they can have like a turkey sandwich, protein, get them something in there to help them. And if they're in the hospital and they have an IV and they're really down, we can give a glucagon injection and it can get that blood sugar up quickly. I'll warn you, turn them on their side, they will vomit. Now, Samoji phenomenon. This is what we call rebound hyperglycemia. The blood sugars are lower at one point, and then all of a sudden, the liver and the muscles just spew out all of this sugar, because glucagon is sugar, right? And sometimes that can happen. You go really low, then all of a sudden really high, and that's Samoji.
Is that the Down,
the question?
the Down phenomenon? I'm sorry.
This is Samoji.
It's okay.
This is Samoji. It's what we call rebound hyperglycemia. It's usually those children who are on large doses. And sometimes we see it at night, because at night it'll go really low. And then in the morning, you're going to see them all of a sudden elevated. So all night long, their blood sugars get low with the insulin. And then all of a sudden in the morning, insulin's worn off. Poof, there's this big blood sugars.
That's what I thought they called the Down phenomenon. But maybe I'm wrong. I thought they called it the Down phenomenon in the med-surg book. There could be something different then.
Could you spell that for me?
It's like DAWN, like dawn as in nighttime.
Dawn. I know, I can look that up for you. I don't know. There's something I don't know. Maybe I'll let you know. I'll send you a message. Okay, so sometimes, the type 2, we know that usually in children, it's usually more of the children that are older, not the younger kids like I've mentioned, but they're overweight. They're not moving and they're eating diets full of, fat. Okay. And what do we do for diabetes too? Does it matter a kid? Does it matter an adult? Well, we're going to do the same thing. Diet and exercise are the first key things that we need to do. And insulin, the oral hypoglycemics, can help control it, but it must be the combination of both of them. So a lot of stuff, huh? Dawn, I have to look that one up. Latrice, are you still with me, my dear?
Miss McCord, I had a question. So I was listening to your review yesterday. So I always know like for like low sugar, someone who is going in the shop, if their insulin is dropping it, they say, give orange juice and stuff. When I was listening to your review yesterday, that was the first time I heard them say you say give protein.
Okay,
I had
you're gonna raise the sugar quickly, right?
yeah.
Now, what's going to happen? It's going to drop quickly. So you need to give the protein to maintain your blood sugar. That's why. And
Okay.
that's the proper education for a diabetic. They go to hypoglycemia, get that blood sugar up immediately. Get them to the point where they can eat and get them some protein in them. Because protein is their major foods at that point, okay?
Okay. Thank you.
Ms.
You're
Bogart, I
welcome.
got a question.
Sure.
Are we able to take a 10-minute break? I know I've never asked for one before because we normally go to like 5:30 straight, but is it
Well,
okay?
we're
to
going
take
to
a
be
10-minute break?
early today.
You
We are going
sure?
to be, yeah, we are out early today. Yes, we
Okay,
are.
because I was gonna leave this classroom, but I'll just ask her to hold off or something.
You can go for a second, take care of what you need to do. All right, and I'll just continue and that's okay. But we will be out earlier today, I promise.
I'll just keep the video on and leave the classroom.
There you go, ma'am. All right, let's see what we got here. This is a very short PowerPoint and then we're done, okay? We're not gonna go late today. You guys, a lot to study for. You've got your reviews that I've already put in there for you. So very important that you study, right? And you've got all these assignments. So I'm gonna give you back a little time because yes, I usually do go too late. So GU, all about the kidneys, right? Well, we're talking sexual abuse. Why? Well, sometimes you're going to see abuse that is manifested by urinating, urinary tract infections. Not uncommon at all, because they have molested, touched, or penetrated. So this could be a problem. We know that if we start seeing younger children excessively masturbating, I mean, children touch themselves. It's normal. But if you see it like increasing to like, this is way too much, something's happened to that child. They shouldn't know about that much yet. And for pieces, I mean, you're getting stool, you'll see it in their underwears. This severe nightmares or night terrors because somebody attacked them, right? Or somebody still is attacking them. Bedwetting when they have not bedwet in a long time. Or again, if you see any irritation, redness, something going on in the genital area, always think that the possibility. I've seen sexual abuse and it really, you'll see these children, they're going to be detached. They don't want to talk, and they're like in a corner. They really go into this emotional depression. Now, okay, so we've talked that. Urinary function. Well, kidneys, how do we go and check them? Well, number one is just a simple urine. That's easy, right? We could see if it's clear, if it's cloudy, if it's got protein, it's got sugar, it's got white cells, all those things we could tell with just a simple urinalysis. An ultrasound, looking at the kidneys, looking at the ureters, the bladder, making sure all of those parts are fine, making sure there's no kinks or reflux. All of these things can help us assess the urinary function. The things that we usually see in children that we're going to be looking for in the urinary tract is pain, dysuria when they're urinating, frequency, and that urgency, and they running to the bathroom, which is not normal. Again, urinating at night, enuresis, or peeing too much, or not at all. And all of those things can occur. So phimosis, this is a boy whose foreskin is tight and you can't pull it back. And the problem with that is you can't pull it back and clean underneath once a day. It's like a petri dish being formed and bacteria grows, and then it will go down the urethra and cause urinary tract infections. My grandson at birth had the tightest foreskin I've ever seen. He needed a circumcision because I could foresee future problems. So it is corrected by a circumcision. Now here we are, Miss Jamie's. Epispadias, hypospadias. Well, epispadias is, now normally you have a penis and you urinate out of the tip of the penis, right? Epispadias is somewhere on the top, the upper portion, somewhere there's a hole. It doesn't come out here, it doesn't connect. It's up here somewhere. And then hypospadias is somewhere on the bottom, okay? Now, usually they like to do surgery before they're potty trained because they want them not to pee out of the side of their penis, right? It doesn't look like daddy, or it doesn't look like the way it should, right? They can't aim it. Let's put it that way. The thing with these things is they need to keep that foreskin on. And why do they need to keep the foreskin? Well, when they do surgery, they literally fillet the penis open under general anesthesia. They create a canal, and in that canal, they place some sort of catheter. And then they close it all up using the foreskin as the graft, okay? Now, you're asking about double diapering. Well, there's an extra tube coming out of the penis post-operatively. And post-operatively, these children, it's a tube you don't touch. You leave it alone. You don't turn it, you don't clean it, you nothing it. You just keep it inside a diaper. Well, to keep that diaper on, not get everything wet, maintain urine output so you can monitor it, we double diapers so they can't urinate out. Sometimes before surgery, if the urine is squirting out a side, up or down, it could also cause urine to squirt everywhere. So it's just to keep the kid dry and to correctly monitor their intake and output. Makes sense, doesn't it? I'm telling you, it is a very impressive surgery. It's general anesthesia done by a urologist who features in neurosurgery, and they literally cut it right down. Now, yes, I know. It's like, ooh. I was always wondering if it took away the feeling for the man, but I haven't read anything about that it did. So hopefully they miss all the nerves, right?
So is the penis in a pamper on its own, and then there's a pamper on top of that pamper to like for the butt? Is that what's going on?
Yeah, you could put like a size 1 on top and then a size 4 over that, you know, just to make sure it's really in there.
All right, I got you. Okay. So to separate
all that means is the double diaper. Yes.
Okay.
You're just catching urine. Now, the exstrophy of a bladder, in a nutshell, is the bladder's born on the outside of the body, right above the symphysis pubis. So the bladder's there. It's still connected. You still pee out of the same place, but the bladder tissue is up top. So what is our concern? That bladder mucosa must maintain moisture and sterility. So we must keep it moist and sterile, right? We're not going to be, usually the physicians change that and those dressings. We don't, okay? You will sometimes get some leakage in there. So you got to be careful of skin, and you've got to keep that mucosa of that bladder moist so that we can surgically put that back inside the body. And it's usually within 2 days of birth. Obstructive uropathy. Well, think of a bladder and your ureters, and there's a bladder, your ureters, and your kidneys, right? Anywhere on those ureters, from the kidney down to the bladder, there's a kink in the hose, obstructive. That could be like that. Could be some sort of scarring, or something tied around it, or it kinked, or it could be kidney stones. Any of that could obstruct. Obstructive means something's not letting that urine go to the bladder so you can pee. That's in a nutshell what it's all about, okay? Now, what happens if the urine doesn't come down and out? It can go to hydronephrosis, and it could really hurt the kidneys. So many times we have to do some sort of urinary diversion surgery. Sometimes we have to be careful. The toddlers, they're not going to be able to do potty training. The school age children, sometimes they'll put even those tubes going when it doesn't come out right and it can't connect. They might even put it to the bowel so that it will be coming out the bowel instead of having a urostomy or a tube on the belly, like a colostomy, a urostomy. And you can imagine an adolescent having something not done properly, especially if the tube came to the outside of the body. Self-esteem. Remember, adolescence is all about identity and body image. Urinary tract infections more common in girls than boys. Why? Well, boys have a long urethra and we have a short one. Simple. And because of that, bubble baths, those cute little tight little pants that we wear today, they're really not good for little girls. Also wiping, potty training, going the wrong way. And sometimes holding their urine can cause this. We know it's usually E. coli from the rectum. So we need to do a treatment. So what are we going to do? Well, number one, you're going to see frequency, urgency, redness, pain, dysuria, all those things you're going to see. Now, number one, we usually, if they have the younger kids, remember, they don't have immune system. And this is a big bug. E. coli is a really big bug. We're going to have to put them in the hospital for IV antibiotics, okay? Now, older children, oral antibiotics work well. The problem is we need to make sure that they increase their fluids to keep flushing that bladder and to do it consistently even after the tract is already taken care of. So how do we prevent it? Well, they should be cleaning well, front to back, no bubble baths, poor girls, right? And children, if they're in the bath, a lot of times I like to pee in the water in the bath. Well, no. Wait till you're done and pee in the toilet, because that eliminates some of the bath water that's gone up there. Use white underwear, cotton, even the dyes are not good for them. Loose fitting pants, those cute little tights that they look so good in, and again, increasing their fluid intake. Now, nephrotic syndrome, I'm going to say this twice, has nothing to do with renal failure. This is not your kidneys not working. This is your kidneys saying, ooh, protein, I don't like you, and eliminating all the protein out of your body. Simple, right? Causes a lot of things. Well, anyway, what happens and how would you suspect this? Well, these children are eliminating all of their protein out. And what happens in the blood, all the protein or albumin in there is really, really low, right? And the body starts to suck the fluid intravascularly inside the tissue. So you get edema. Eyes will be swollen. Again, you're going to be swollen up with this. What we do for nephrotic syndrome is we give them steroids, okay? And these children, we're going to be knowing it's working because we're going to be doing intake, output, and daily weights. What do you see? Well, edema, weight gain. So if you're seeing it losing, we know it's working. They also become pale, irritable, listless. Their appetite's bad because even in the inside of their mouth, they've been chewing on it because it's so swollen and it hurts. If you're gaining fluids, what will you see? Well, you're not going to breathe pretty good. And your blood pressures are going to go up. Too much fluids, like congestive failure. Heart rate's up, blood pressure is going to be going up. You're going to see that protein or albumin in the blood. And a lot of times, we're going to see these children go into neutropenia, which means they become immunosuppressed. Their white blood cells go low. They cannot fight infection. So we got to worry about infection and weight and intake and output. So we give the steroids. We also decrease how much medicine they get because there's no protein. There's nowhere for the medicine to hop on. So it's free flowing in the blood. So your levels are going to be high, become toxic. I mean, you could become toxic on one pill when you, at this point, you need a baby dose when you're 8 years old, and it could happen that way.
Ms. Bogart, I have a question.
Sure.
You know how you said with nephrotic syndrome that the blood pressure will go up, but you see on the last slide where it say it stays normal sometimes, like if we had a select all that apply and we put that the increased blood pressure was going, would they take that? You know what I mean? Because I know it said like with nephritis, the blood pressure will go up, but on nephrotic syndrome,
With
it's still
all of the
usually
swelling
normal.
and stuff that's going on, you
Yeah.
know, it says normal. I've always seen it go really high.
So would it be like if it was on a select all, would y'all give
You'd
points
have
back
to
for
say
that?
normal because that's what the
Say
book
normal?
says.
Oh, okay.
Jamie, thank you. That was a great question. I appreciate that. Diuretics don't work. You know, you can give all the diuretics you want because why? It's not intravascularly, it's interstitially. You got to pull the fluid out of these interstitial and out of the tissues and put it back into the blood system. So it doesn't work. So what do? We limit fluids and we restrict salt. So these children, as I said, intake, output, daily weights. They have to really watch their medications given it when they need to, and be careful. They can be toxic, so to know those signs. Because they're immunosuppressed, no live vaccines. Think about that. When are you immunosuppressed? Well, this is one of them. Steroid therapy, you shouldn't take live vaccines. You become immunosuppressed, especially nephrotic syndrome. These children, if they're in bed because they have dependent edema, keep them moving up, you know, walking, changing them side to side if they can't get out of bed. As I said, strict INO and daily weights. And wear your gloves, protect them. That's the biggest thing we could do. Acute glomerulonephritis is due to a recent streptococcal infection. And what happens is a kid comes in and he stops urinating, blood pressure goes up, the urine looks like foam, and you start to swell. And that usually brings that child in for treatment, where they ask, have you been sick lately? And if they said that they have had a sore throat, they're going to say, okay, I know what happened. And acute means it's curable. Chronic means it's not curable. So acute glomerulonephritis, you treat the strep infection, and usually they'll recover in a couple weeks. They're going to be monitoring, of course, because they were oliguric or not urinating. You're going to be monitoring if they're urinating, and you're going to be monitoring fluid intake and blood pressures during this time. Wilms tumor is a tumor on the kidney. It's usually African-American boys ages 3 to 5. I've seen one. It was a child from Haiti after the Haitian earthquake. And our hospital went down there as a mission, found this child, and through some religious whatever, they got him up here. And he appears on my triage desk. And I asked, so what's going on? And these people who brought him from the airport said, I don't know. Here's his records. They were in French. Now what do I do, right? Now I have to go back to doing an assessment. What I found, And it was hard because I had to get on this child's level. He was 3 in a new country, looking at me, going, I'm scared. And I got on his level, sat down lower than him, and I just gave him a sticker, made him feel whatever as much as I could. Say, parlez-vous français? Je parle un petit peu. The little bit that I knew. And he smiled. And then I listened to his chest, listened to his abdomen, and on that left lower quadrant was a softball-sized mass, and it is malignant. One of the things about Wilms tumor is you cannot touch that belly because that tumor is fragile and it will put metastasis inside the belly. So leave it alone. Again, it's to do with the kidney, so you have to worry about blood pressure. That tumor, we do not do a biopsy or anything on it. We might do radiation or chemo, but the surgery needs to go in and remove the entire thing. And they usually have 100% cure. So again, the biggest thing is leave the belly alone, all right? Do not palpate the abdomen. Should it be sign on the bed, over his bed, on the chart, everywhere? Hydrocele is fluid in the testicular sac, and it actually hurts. Usually, sometimes you see it swells and we can't cure it, and sometimes it might need surgery. Cryptorchidism. The testicles are up inside the body and they can't fall down. Now, one of the things that we need to do with this is when we are checking for cryptorchidism, we might ask that the room be warmer so that the balls, the testicles will fall, right? Testicles are warm, they tend to fall and sag. When they're cold, they suck up. So we want a warm room and we'll check them, okay? If we keep it up there and we just let those testicles stay in the abdomen, it's too hot and it will cause sterility in that male. A lot of times it could be due to a tumor, so we have to be careful. A lot of times they'll do hormone therapy before, try to get it down there, but many times we're going to have to do surgery. So nursing care, well, you need to hold the testicles, which means put on a good pair of underwear, right? That's the way you would do scrotal support. Tell them to keep the suture line clean because it's going to be right in there. Have them test their own testicles when they're old enough, okay? This should be that monthly thing they do on all the time. And a lot of times the little boys are afraid because it has to do with his balls and his penis. Oh my goodness. They get scared like they're going to be castrated, which is one of their fears. So make sure that we let them know that we're going to leave all the body parts there and it's going to be okay and nobody's going to look at them, only the doctor. And those things actually do help with that. So urinary and genital surgery. Remember, these children are worrisome. These are their private parts. This is where they start getting shy. They want to go to the bathroom alone, many of them. So make sure that we let them know why these things are going on. As I said, they get really curious at these ages, and it's in that preschool area where they start fondling and touching themselves and masturbating. Normal things, okay? So preparing these children for what they're going to feel after surgery is exactly what we need to do. Any questions by anyone? Now, I'm going to send you all a Kahoots. You also have it on your announcements. It's the week 8 Kahoots on your exam review that you can look at your leisure. I am going to end lecture today. I think we've covered everything we need to do. The one thing that we didn't sort of look at was immunities, and that is covered on the Kahoots. I made sure a couple of the last questions were there. Any questions by anybody? Well, you all have a good Friday night and a great weekend. Any questions, please shoot me a message and I'll get back to you as soon as I can. I appreciate your patience.
Have a good weekend.
You too, my dear.